All right. And I think we've got our AV guy and Dr. Kelsey all set up with his stuff. So this is, it's really exciting. You are all really lucky because we don't often have a radiation oncologist at our programs, and I always get really thrilled and excited when we have the opportunity to have a radiation oncologist. And you weren't here this morning when I shared a little bit about my story, but this is like my favorite form of treatment, and I've had a lot of it, so I should probably be glowing. But for me, it works really, really well, and I think it's something we don't often talk about, but I would love to be able to share more about this particular variation of therapy, because again, personally, have found it extremely effective over the course of a good 20 years. And, and again, so it's really a treat and an honor, and we're really thrilled. Thank you for coming, and I'm gonna turn it over to you to talk about radiation therapy.
Okay. Well, it's a pleasure to be here with you today, over here in Raleigh. So I'll be talking about different ways we use radiation therapy to treat a variety of cutaneous lymphomas. And the goal of this is to try to demystify, because radiation is this obscure modality that's usually in the basement of hospitals. There's no windows, there's lots of lead. This is sort of what people think about with radiation, this glowing sort of force, this force field that you get. So we'll try to demystify this. So I just want to take a huge step back and just illustrate what radiation is, just so that you can get a kind of put this in perspective. So radiation is simply an electromagnetic wave that propagates through space. And there's an electric field component, and there's a magnetic field component. They're perpendicular to each other, and all radiation is simply these waves of packets of energy, okay? And you are familiar with all sorts of different types of radiation. So radio waves are these photons, microwave, infrared, visible, UV, X-ray, gamma rays. I'm sure most of you have heard of these different things. And you might imagine, well, what's the difference between X-rays that we're using to treat cancer and microwaves that we're heating up our pizza with, okay? So, but it's all the same. They're just these packets of energies that propagate through space, with visible light sort of occupying this position in the middle of the spectrum here. And if anybody has any questions, feel free to just raise your hand and we can address things as we go. So what's the difference, okay? So going back to this, what's the difference between microwaves that seem so harmless and ubiquitous, we all have a microwave in our house that we use, and X-rays where you have to come to our department into the basement with lead shielding this thick, okay? So what's the difference? The difference is that some types of radiation are ionizing. So ionizing radiation is where that photon is propagating through space, and it has enough energy in it to eject one of these circulating electrons. So if you think back to high school physics, you had an atom that was composed of a nucleus, which was protons and neutrons, and then surrounding and orbiting the nucleus were these electrons. So microwaves do not have enough energy to eject an electron. So when you put your pizza into the microwave, it cannot make any changes in the chemical composition, really, of that it can heat things up, but it's not going to change things. But X-rays and gamma rays that occupy that high energy end of the spectrum, they have enough energy that they're going to eject that electron. And when that electron goes flying outside of the atom, it can cause biological changes that can be used to treat cancer, okay? So ionizing radiation are X-rays, gamma rays, as well as ultraviolet rays. So UV light is potent, and you have to be very careful of that. Now, on the other hand, non-ionizing radiation, radio waves, microwaves, most of the visible light spectrum. Okay? So this is the big difference. And you may say, what's the difference between a gamma ray and an X-ray? So X-rays are created by machines. Like you go get an X-ray, and a machine will make an X-ray photon field that will take a picture of your chest. A gamma ray is when you actually have a piece of radioactive rock, for example, that decays. So uranium, it decays, and it may decay into radon, and then eject a photon to release its energy. Okay, so it's just how that photon is created is the difference between X-rays and gamma rays. But in the radiation oncology department, we're primarily using X-rays because we have these machines that make X-rays, okay? So all of you, right now, whether you like it or not, are being radiated, okay? Because radiation is ubiquitous. This is the high energy radiation, not just light rays, but actual potent radiation we're being exposed to every day. So the biggest component is radon. So radon is a byproduct of uranium and radium. And radon is very prevalent, not so much in North Carolina, but in the West. So where I grew up in Wyoming, radon is a big problem. Like one of my dad's friends built this nice big house up on a hill, and then when he went to sell it, he found out that there's a lot of radon in his basement, and it made it very hard to sell that house. So radon is an issue because radon can cause lung cancers and other things like that. Cosmic, so if you go up in an airplane, you are exposed to radiation because that's what the aurora borealis is. So the aurora borealis is radiation just flying through from the sun, and it hits the gravitational waves of the Earth that bends those radiation packets, and it causes all the lights. Okay, so the aurora borealis is this. So if you're up higher in space, you're going to be exposed to more radiation. When we eat our food, there are very trace particles of radiation in our carrots, in our potatoes. Okay, it's everywhere. And then finally, not so much in North Carolina, but in Colorado, Utah, those areas, there's a lot of radioactive rocks in the earth, and they just sort of cause this radiation to seep through the earth, and we get exposed to it. So the average American is exposed to 3 millisieverts of radiation a year. This is a really small amount, okay, when you put it into perspective of what we treat people with. But the annual radiation exposure to the average American is twice that, because they get 3 millisieverts from just living, mostly radon, but some space, internal, and terrestrial exposure. But everything else is, you go to the radiology department, you get a CT scan, you get an X-ray, you get a fluoroscopy. Okay, so all of these medical uses of radiation is where a lot of our exposure is. And this is actually a big deal because we know that little kids, for example, who get lots of CT scans, they're at a higher risk of getting cancers from these radiation. Okay, so this is how ionizing radiation kills cancer. Okay, so we talked about how you have a high energy photon, it comes in, it ejects the electron, and that electron can do 2 things. One, it can interact with water, which is everywhere, and create hydroxyl radicals, and the hydroxyl radical damages the tumor's DNA, and the tumor cell dies. Or the photon can come in, hit the electron, and the electron itself can damage the DNA. This actually happens less frequently than this. This is the primary way in which radiation kills cancer. So if you just sort of think what radiation is doing to kill your skin lymphoma, the machine turns on, photons go through, it will hit different matter in your body, which will create these electrons that go flying out of an atom. It'll hit water, make hydroxyl radicals, and the hydroxyl radical damages the DNA and the cell dies. So that's radiation. Any questions about that?
So simple, right?
So simple. Okay? That was like 3 years of my education, all in like 15 minutes. All right, so let's talk about therapeutic radiation. Okay, so you get referred to see a radiation oncologist. So this is how it works. The first day you come is you just meet the radiation oncologist who will evaluate you, look at your skin, talk to the other doctors, and make a plan. The next step is simulation. Now, for most skin lymphomas, the simulation is usually pretty simple. We just often have to draw out where on the skin we're going to treat with radiation therapy. But it can be more complex. In fact, for other cancers that we treat, the patient will first get a CT scan so that we can visualize the tumor internally and then design radiation fields that will treat the tumor in kind of a virtual computer space. And this all happens when you are back at home, and then you come back a few days later to actually start your radiation therapy. But most skin lymphomas, because they're just on the surface, we don't need to go through a lot of these extra steps. And then you get your treatment. So this is called a linear accelerator right here. So here's the bigger picture. So when you come into the radiation oncology vault, again, it has 3 feet of lead all around it so that this radiation doesn't escape elsewhere. This is the machine. So this is called a linear accelerator. Again, there's no radioactive components to this machine. Now this is different than it used to be. So we used to treat people with cobalt machines. So cobalt was where you had a radioactive rock right up here in the head of the machine. And it was constantly emitting radiation, like 24/7. But you'd have these big jaws that would close so that radiation couldn't go out. And then when you had the patient all set up down here on the treatment couch, once it was time to treat the patient, then the aperture would open to the appropriate size to treat the patient. And then it would close up again. Okay? But we don't, those are just complex. And as you might imagine in today's society, with all the fear of nuclear weapons and things, having big pieces of radioactive material in a hospital is not a great idea. But if you go to a third world country, cobalt is used all the time because they're much cheaper machines. So the patient lies right here. Sometimes we use these arms. These are arms that come out like so, and we can actually do a CT scan out of the machine if we need to. But the radiation starts back here, comes down the head, does a 270-degree loop, and then comes right through here, right through this aperture to treat the tumor. So, and we'll talk about different ways we use radiation. But just a couple of terminologies. So sometimes you hear the word gray. Gray is a unit of radiation. It's like when Edith is prescribing Targret, she gets so many milligrams, right? This is gray. Gray is our dose. Okay? And 2 gray is a typical daily dose that we use to treat lots of types of cancer. And if you remember 2 gray as sort of a benchmark, that might put into perspective what kind of radiation doses we need for lymphoma. And then a fraction is a treatment. So most of our patients are treated every day of the week, Monday through Friday. Like if you have breast cancer, you come in for a 15-minute treatment 5 days a week. So you get 2 gray a day for 5 days a week, so you get 10 gray a week. And if you need 60 gray of radiation, it's 6 weeks of radiation therapy. So just to give you an example, if you have primary cutaneous B-cell lymphoma, and you have one spot, you have unifocal disease. And Dr. Bevan sees the patient and says, this is perfect for radiation. You come see me and I'm going to tell you that you're going to need 30 gray of radiation. Because that's a pretty standard dose. 1 dose a day, 5 days a week for 3 weeks. All right? Okay, so types of radiation. So the most common types of radiation we use for lymphomas are electrons and photons. So electrons are a special type of radiation that doesn't penetrate very deep into the body. It's superficial, okay? And so, and a radiation machine will have like 8 different energies of radiation, of electrons that you can choose from. So you can gauge how thick the tumor is, how deep it may penetrate into the skin, the total depth that you want to treat, and then you can choose what electron energy you want to use. So for example, in this particular example here, this is a low energy electron beam where 100% of the dose is at 1.5 cm. So these little lines are like a topography map where it's like different, instead of being different elevations, like a topography map, it's different doses. So you go from 100 to 95 to 90, 80, 70, 60, 50, 40, 30, 20. So once you get to 2.5 centimeters, you're down to 20% of the dose. Okay, so the dose falls off very fast. So here's an example of, here's an example of a patient that we treated with electrons. This is a 43-year-old male. He noted a pimple as he described it. On his left flank in November 2010, this is a patient I saw some time ago. In 1 month, this thing just exploded and grew to like 5 centimeters. It was painful. Numerous biopsies were done, which were not diagnostic. He was treated with topical and intralesional steroids, which caused some waxing and waning of his disease. But after about 3 months since he noticed this, a biopsy came back as primary cutaneous anaplastic large cell lymphoma. And so he had this fairly large, raised, red, ulcerated. You can see how the skin's breaking down. It's weeping. Very painful lesion. He was on pain medicines, pretty miserable. He had scans done which showed no evidence of cancer anywhere else, and he was diagnosed with primary, so it's stage 1, primary cutaneous anaplastic large cell lymphoma. And with stage 1 ALCL, we often treat with radiation therapy. And so when patients come in for treatment in this particular circumstance, it's pretty simple. This is one of the simplest things in terms of planning that radiation oncologists do. It's like kindergarten. You just sort of draw out what you want to treat, you know? And this patient had all these little satellite lesions. So I thought it might be wise to be kind of generous. So I wanted to treat not only the spots that I could see, but put a couple centimeters all around it to make sure I was encompassing what I couldn't see. So this was sort of his back that we designed this radiation field. This area was so big that we had to cut it in half because our electron machines can't treat an area that big. So again, we talked about how different energies can be used to penetrate a different depth. And this patient had a lesion that was pretty thick, so we had to use, I think we used a 9 MeV beam. But anyway, patient came to our machine, they lied on their stomach, and this is the head of the machine. And you can see that that was one of the radiation fields, and then the budding field was right next to it. And he got 4 weeks of radiation, 15 minutes a day, and at the end of treatment, the lesion had completely regressed. And you can see the hyperpigmentation from the radiation. It's like a little bit of a tanning effect. This will fade. Sometimes patients will have some persistent tanning of the skin, depending upon the dose of radiation you use. Especially a dose of 4 weeks, it's not uncommon for there to be some more permanent tanning, but this was pretty soon after he finished, and it faded over time. So the prognosis of primary cutaneous anaplastic large cell lymphoma is very good. This is survival, and if you look at cancers like lung cancer, colon cancer, survival kind of comes down like this. But primary cutaneous anaplastic large cell lymphoma, at 10 years, 80% of patients are still alive. So this is, even though it looks really bad, the prognosis is not too bad. So any questions about using electrons to treat patients with lymphomas?
Now, refresh this again. You said there's no danger of any harmful effects from the body.
Well, not. So the electron beam does not penetrate very deep. So if you're treating a lesion on the back, for example, there's really not going to be any radiation to the bowels, the lung, so those internal organs. So the main thing that is being treated is the skin. And the 3 main risks of radiation to the skin are pigmentation changes. Sometimes people can get thickening of the skin, like fibrosis. Scar tissue can develop, especially with high doses of radiation. Usually not so much with the doses we're talking about. The other risk is skin cancers. Just like you can get that with PUVA, narrowband UVB light therapy, you can also get it with radiation therapy. Again, the incidence is really low, but not zero. It's hard, like as Edith mentioned, it's hard to detect and demonstrate what the actual risk is because the incidence is so low and the background risk of getting skin cancers is so large. So it's a small risk, but it's a risk. Those are the main things.
Benefits from this? I mean, if you have stage 2, would you be a candidate for this, or would you have to have more like a tumor before you would be a candidate for this?
For radiation?
Mm-hmm.
Oh, so it all depends upon what skin lymphoma you're treating. So there are a dozen or more different types of skin lymphomas. And for most skin lymphomas, with one notable exception I'll talk about, if the disease is localized, there's only one spot. It's not multifocal. For most skin lymphomas, if you have a single lesion, we almost always use radiation therapy as a potentially curative modality up front, with some exceptions. In patients who have more widespread disease, like I'll talk about here, radiation is mostly used for lesions that are not responding well to other modalities. Usually modalities that are less intense or modalities that are more comprehensive in their treatment. So it very much depends on the circumstance, but for this particular disease, primary cutaneous anaplastic large cell lymphoma, if there's just one lesion, then radiation therapy is the preferred treatment. Now here's an example of where radiation is used in more of a palliative setting. So we use palliative as a term where it's not, the intent is not to cure the cancer. So a lot of skin lymphomas we never cure. A lot of these are low-grade, chronic conditions that people live with for their whole life, and we just manage them. But we can use radiation as a very effective modality to help in that management. So here's a good example. This is a 42-year-old guy who came to see me because he had multiple bumps on his back, and shoulder and right arm that had progressed over some time. He had a biopsy done, and it was marginal zone B-cell lymphoma, so this low-grade B-cell lymphoma. And if he only had one spot, then we would typically treat with radiation therapy alone. But he had like a dozen of these things. And so he was first treated with topical steroids, and well, I guess he had 5 of these lesions. So he had 4 of the lesions went completely away, and 1 lesion hardly budged. And this was the lesion that hardly budged. It was on his left shoulder, it was itchy, it was sort of cosmetically annoying for him. And so, because the topical steroids had taken care of everything else, he was referred to me just to treat this 1 lesion. Now, if we're treating people in a palliative setting, where we're just trying to give a low dose of radiation to make a lesion go away or shrink or whatever, we can use a much lower dose, okay? So this patient, we treated 2 gray times 2. So this is a tiny dose of radiation. To put it in perspective, when we treat prostate cancer, we give 80 gray, 80. And this is 4. Okay, this is just a whiff of radiation. You just kind of blow on it. Okay. So two treatments of radiation. So he came in the first day, and we made a little. So again, we wanted to treat the lesion, treat a little bit of microscopic disease, stuff we couldn't see around the immediate periphery. So pretty small radiation field. And 2 months later, it was completely gone. So with 2 doses of radiation, about 80% of these will go away or significantly regress. And I treated this person probably 5 years ago. And about every 2 years, he comes back to see me with a new spot. And I give him 2 doses of radiation, he goes on his merry way, and a couple years later, he comes back with another spot. And this has been very durable. So we treated this about 5 years ago, and it still hasn't come back. So for these low-grade lymphomas, especially the B-cell lymphomas, very low dose of radiation can be very effective. So this is another patient that was treated. So just some more logistics of how this works. The patient came in to see me. I drew out a radiation field that would encompass the lesion, plus a little bit of safety, a little wiggle room to make sure I get it all. If there's some microscopic disease under the skin, I want to make sure I treat that as well. We create these little lead cutouts that will create this dose field on the patient, and they lie on their stomach. Here's the head of the machine. We put that cutout right there, and then you'll notice that there's this clear material that lies on his skin. The purpose of that is that when a radiation field hits the skin, it takes about 1 centimeter to build up the dose to get the full dose. So the radiation has like a skin sparing effect to some degree. So we put this on top so that when the radiation beam hits this material, the dose starts to build up such that when it hits the tumor, 1 centimeter under, the full dose is being delivered to the tumor. Okay, so if any of you get radiation and they put some wet towels on top of you or some mushy stuff like this, that's the reason why. Okay, it's called bolus because we're trying to make the radiation beam adequately treat the tumor. And so here's a study from the Netherlands that shows how effective low dose of radiation is for these low-grade B-cell lymphomas. So this is primary cutaneous marginal zone or follicle center, 2 grade times 2 doses of radiation. The complete response rate was 75%. So 3/4 of patients, the lesion goes completely away. The partial response rate was 86%. So an additional 10% or so of patients, it shrunk dramatically. And the durability can be several years. And so sometimes we use these just low doses of radiation just to keep things in check, to avoid having to give patients higher doses of medicines or shots or things like that. All right, so those are electrons. So electrons are pretty straightforward type of radiation. It's the simplest thing we do, where there's something on the skin, we just draw out what we want to treat, and then electron beam will treat it. Now, more complex is an example like this. This is a patient with Mycosis Fungoides who has a tumor that was on the surface of the skin that penetrated deep, deep, deep down. And this is not uncommon. And so if you use electrons, you can't treat this very well because it's too deep. This is like 6 centimeters from there to there. And right next to where the tumor is, you have intestines and stuff. So you have to treat patients a little bit different. So this is a circumstance where the patient will come into our department, we'll do a CT scan, then the patient goes home, and then our treatment planning, we draw out where the tumor is, and then we design radiation fields that will maximize treating the tumor, but avoid treating other things. So for example, in this patient, the tumor is right here, and they got a radiation field that came from this direction, and this direction, that creates this nice dose distribution right around the tumor. So in this circumstance, the underlying intestines do get a low dose of radiation, but the tumor is getting the full dose of radiation. And again, most of these skin lymphomas require such a low dose of radiation that side effects or any risks to the underlying organs is really low. So for example, if we were to give this, let's just say 10 gray of radiation, so 1 week of treatment, the intestines can tolerate 50 gray without really any risk of problems. Sometimes they'll get some loose bowel movements or some irritation, but that's transient. But the risk of any like serious harm or damage, like scar tissue or things like that, are very low as long as you're under 50. And we're usually giving like 10. So there's a lot of, so it's really nice from radiation oncologists to treat skin lymphomas because the risk of toxicities is really low because we use such low doses. All right. So I mentioned earlier how there's all different types of cutaneous lymphomas. Mycosis Fungoides is by far the most common. So 75% of skin lymphomas are T-cell, and Mycosis Fungoides is the vast majority of those. So I'll talk a little bit about Mycosis Fungoides later. And then we also talked about the other major T-cell cutaneous lymphoma, anaplastic large cell lymphoma. That's less common, and it has to be distinguished from this benign skin disorder called lymphomatoid papulosis. These two can be tricky because they look the same under the microscope for all intents and purposes. And then we also talked about primary cutaneous marginal zone lymphoma. These are really easy lymphomas to treat with radiation therapy. So let me just talk a little bit more about primary cutaneous marginal zone B-cell lymphoma. So there's 3 different types. There's marginal zone, there's primary cutaneous follicle center, and then there's diffuse large B-cell lymphoma leg type. And if you want to just be make it very simple, these are very good, these are good, this one's bad, okay? This is one where we don't, if there's just one spot, we are not going to treat it with just radiation, because that's not going to be enough. If I see a patient who has this, I'm getting on the phone, I'm saying, Ann, Bevan, I need you to see this patient. So this just gives you a sense of the difference between these two. So this is disease-specific survival. The chance of dying from your lymphoma is low in these marginal zone and follicle center lymphoma. The vast majority of patients live their normal lifespan, and the lymphoma is this nuisance. But large cell lymphoma leg type is a different entity, so we have to treat it different. So this is a patient that we treated at Duke some years ago, 54-year-old guy, had a bump on his scalp. And they did a biopsy, and it was called a wart. So he felt reassured, it's like, why is there a wart on my forehead? It's a weird spot for a wart to develop. But then the lesion started to grow. And he had 2 more biopsies, which were also negative. And this is a phenomenon we see a lot in skin lymphoma. Sometimes it's hard to really get these diagnosed early. But then this thing really started to grow. And they did a biopsy at Duke, and they said this is primary cutaneous DLBCL leg type. And this was a picture of the lesion. So there's this fast-growing, raised lesion. It's ulcerated here in the middle. And you look at this, and you're like, this is not one of these low-grade B-cell lymphomas that is growing slowly, that's indolent. This is an aggressive lymphoma that needs to be treated more aggressively. This is a PET scan. So we don't get PET scans all that frequently. In skin lymphomas, they're usually not necessary, but in a patient with an aggressive lymphoma like this, we want to make sure it hasn't spread anywhere. So a PET scan is a whole body scan, and here was that lump on his forehead, and it lit up like a Christmas tree. Now the brain lights up because we're thinking all the time. But there should be something hot like this on the scalp. But fortunately for him, there was no disease anywhere else. And so he went on to get 3 cycles of chemo. And we're not usually giving chemo like R-CHOP, which is a 5-drug regimen for skin lymphomas. We do for this one. So this was before the chemo, and this was after the chemotherapy. So he had a really good response to treatment. And this was the PET scan before, and this was the PET scan after. And there was just this mild warmth where the tumor used to be, which is probably just healing tissue. Now, in these aggressive lymphomas that are localized, we often do radiation therapy afterward as an adjuvant modality, sort of an insurance policy. Because we know that in patients with localized lymphomas, they get chemotherapy by itself, there's a higher risk that will come back right where it started. So we'll use radiation therapy to treat the microscopic disease that may have left. So he got 3 weeks of radiation treating this little area right there. Okay. Okay, let's talk about Mycoses Fungoides for a little bit. So this is probably the most common skin lymphoma that I treat. The median age is around 57 years. This is primarily a disease of adults, but we do see even people in their late teenage years, young 20s, that will get Mycosis Fungoides. So it does happen in a younger cohort. It's still relatively rare. So there's about 5 cases per million people. There's 10 million people in North Carolina roughly. So every year about 50 people are diagnosed with mycoses in this state. And there's a long duration from the onset of symptoms to diagnosis. Patients will often be diagnosed with eczema or psoriasis before the mycoses is discovered. And that's not uncommon. It's just sometimes very difficult to nail the diagnosis quickly. It's more common in males and blacks for reasons we don't always understand. And patients have different types of mycoses. There's this wide spectrum between patients who may have one tiny little patch and another person that may have widespread disease. And for all but the earliest, this is like a lot of skin lymphomas. We don't cure it like we cure leukemias, for example. Some people will say, well, get chemotherapy and I'll never have to deal with this again. Usually, for most patients, mycoses is something we manage. We keep a lid on it. That's our goal. So Mycosis Fungoides, patients will have either these thin, poorly demarcated patches, or more demarcated, slightly raised plaques. Tumors can develop, and then there can be erythroderma where there's not really discrete patches of disease, it's just the whole skin has this deep reddish hue, and that's often associated with Sézary syndrome, where there's often blood involved. We talked about how there's this wide range of diseases. Everybody's different. So first, what I'd like to talk about is how we use radiation for potential cure how we use radiation for local palliation, and then I'll talk a little bit about total skin irradiation. I won't go into transplant. So every once in a while, you'll see somebody with Mycosis Fungoides who has one patch or one plaque. Not commonly, okay? So here's an example. 45-year-old female had a slowly enlarging plaque on the left arm. It was Mycosis Fungoides. On physical exam, there was nothing else. No enlarged lymph nodes, no blood involvement. CT scan was unremarkable. And they were diagnosed with unifocal stage 1A Mycosis Fungoides. This is a rare bird. And like I mentioned, for most low-grade skin lymphomas, if there's just one spot, we typically treat with radiation therapy. So just to give you a sense of how rare this is, this was a study from Yale. Yale has one of the largest skin lymphoma programs in the country, and they have many publications. So this was a publication looking at patients from 1954 to 1996. In the radiation oncology department, they had 900 patients who were seen. And of them, only 13 had unilesional MF. So it's very rare. And a few other people had 2 or 3 spots in close proximity. But these 21 patients who had minimal 1A disease were treated with radiation therapy. The complete response rate was 97%. So we can always make the lesion go away. There were 3 patients who got radiation and the disease came back right where we treated it. And they were treated to doses of 8, 20, and 20 gray, which, again, these are patients that were treated in the 50s, 60s, and 70s. Now we know that we really need to give a dose of at least 30 gray to make these go away for good. But even with often inadequate radiation, at 10 years, 64% of the patients, the mycoses had not come back. And they were likely cured of their disease. And of the patients who had just one spot and got a reasonable dose, the outcome was even higher. 90% of those patients were long-term survivors. This is a study from Milan, which shows basically the same thing. Good dose of the complete response rate for these unilesional patients is high, and the relapse-free survival, half of the patients, the disease didn't come back. So every once in a while, I'll see somebody with one spot, and I think doing radiation therapy is a very good, potentially even curative treatment. But most patients do not have just one spot. So here's another case. 62-year-old female, she had skin nodules for a year, like we talked about. She was diagnosed with eczema for a while, and then she eventually was found to have Mycosis Fungoides, and she had multiple ulcerating bleeding tumors. So I hesitate always to show some of these pictures, but mycoses can present with serious problems. So in this patient, there was a large tumor right on the thigh. You can see the additional disease on the buttocks here, but very deeply ulcerated lesion. And we treated her, and let me see, yeah. So when we treat these large tumors, we can almost always make these heal. Because until you get rid of the mycoses, they're never going to heal. Because the mycoses is like an acid almost in there that impairs healing. But once you get rid of the lymphoma, it'll heal. And it may take 8, 9 months for these things to heal. Because the skin has to heal from the bottom up, the outside in. But they'll heal, but it just takes time. Now we use radiation in patients with mycoses in a few circumstances. One is where there's just a couple spots that need some radiation. So if let's say they're getting interferon and target, for example, and everything's well controlled except for 1 or 2 or maybe just a few spots. We can do sometimes 1 dose of radiation and make a lesion go away. So this is from Northwestern University, 58 patients with Mycosis Fungoides. They treated 270 areas with 1 dose, just 1 dose of radiation, 1-day treatment. And the complete response rate was 95%. And essentially everybody had a good outcome. So there's a lot of patients where we can do one dose. Now, we can only do that if the lesion is reasonably small in an area that's not super sensitive. So if you have a really large tumor, we can't do this, it's just not safe. Or if you have a tumor that is in a very sensitive location, like next to the eye, or in another critical location where we have to spread it out a little bit. But in some patients, we can just give one dose of radiation with a good response. Now, the other thing that we do is total skin irradiation. So sometimes patients have widespread disease, especially when they have thick plaques or tumors, because a lot of treatments just don't penetrate deep enough. If you have a very thick plaque or a large tumor, in radiation, we can modulate the beam to treat as deep as we want to go. So in those circumstances where there's widespread disease, we'll do total skin irradiation. Now, this is sort of a funny treatment for not only radiation oncologists, but for the patients, because you have to classically stand on this pedestal and assume these sort of Egyptian poses to expose your whole skin surface to the radiation beam. Unlike this figure seems to demonstrate, you don't have to be naked up on the platform. People often ask me that. You can have a gown on and things like that. But it's long. It can take an hour, sometimes 2 hours, depending upon the circumstances, to give the treatment. Now, I try not to include any patients that I've treated that live anywhere near here in this presentation. So I had to find some pictures from the internet. So this is a picture of total skin electron beam therapy in like Moldova or something. You know? So this is not how we do it, but it gives you a sense of how it works, okay? So the patients, we have to put these eye shields, like these lead contact lenses, into their eyes because, again, the radiation field doesn't penetrate very deep, but the eyelid is so thin that the eye is on the other side, so we have to protect the eye. And then we also have to put these shields in their mouth so that radiation doesn't seep through the lips and hit their gums. So the patients are in this, the way that we do it at Duke, on this stand, and they have their eyes blocked, they can't see, they have a shield in their mouth, they can't talk. So you can kind of get a sense of how awkward this can be for the patients. Sometimes it's hard for us to communicate well, especially if people are hard of hearing, and so forth. And then, in the way that we do it at Duke, we have a platform that has these pegs for people to hold on to. In this particular arrangement, it looks like they have some ropes that come down and just help hold people's arms in the right position. But you know, it's challenging. This is a challenging treatment to receive. Now at Duke, we have commissioned a technique to treat people lying down. And this is really nice because we have lots of patients that for one reason or another just can't safely stand for an hour. And that works well. It's not quite as good in terms of how well the dose is given compared to standing up, but it's pretty darn good. So there's pluses and minuses of everything, but the lying down technique has been something that Duke offers now. And there's only 2 other centers in the United States that have that capability. MD Anderson in Houston and the Mayo Clinic in Rochester, Minnesota. So we're happy to provide these services for people that can get total skin electron beam therapy otherwise. So as I mentioned, total skin irradiation for mycoses is optimal if there's widespread disease, if you have to treat the whole skin. Now sometimes you'll have patients where they've never had disease of the face. It's always been, you know, the neck down. And we can just shield the face. So we can customize the total skin treatment as well. But it's optimal for widespread disease, especially if there's thick plaques or tumors where other modalities just don't penetrate deep enough, or when other things have been tried and they just aren't working, okay? So there's 2 different ways we do the radiation. I'm sorry, this is sort of technical, but we either give a full dose of radiation, which is sort of a conventional way to do it. That's 6 weeks of radiation, 4 days a week for 6 weeks. And then the other way is to treat people with 2 weeks of radiation, Monday through Friday for 2 weeks. And depending upon lots of circumstances, how much disease they have, have they had radiation before? How are they responding to other treatments? How thick is their disease? We'll decide between those two modalities. And we use the eye shields, as we talked about. Sometimes we have to boost underdosed areas. So there's some areas that are just shielded from the radiation beam based on normal anatomy, like the upper inner thighs. Or if somebody has a little bit of a belly, sometimes the skin underneath their abdomen doesn't get adequately treated, or the very top of their head, the vertex. So we sometimes have to do the radiation, have them come back about a month later and just see what's left, and then treat that. All right, but what do you get from radiation therapy? So it's a conventional dose of 5 to 6 weeks of radiation therapy based on the Stanford data. If you just have patch plaque disease, so no thick tumors, 3/4 of patients, the disease will go completely away. And the other 25% will have a very, very good response. But if there's tumors, then the outcomes are not quite as good. But still, half of patients will clear their skin. Sometimes it takes a while for those tumors to regress or ulcerated lesions to heal, but the radiation works very well. Essentially, 100% of patients will have a very good response. So in summary, I think this is my last slide, radiation therapy is a very effective treatment for almost every skin lymphoma. Even the most aggressive skin lymphomas, like the gamma deltas, radiation can be used to improve outcomes. The type of radiation, the number of treatments, the technique can vary dramatically. But sometimes it's just one treatment, and sometimes it's up to 24. So it just very much depends upon the circumstances. And for most people, the radiation is tolerated pretty well. Again, it depends on if you're treating the whole skin, where you're going to have more side effects, or if you're just treating one spot on the arm, where you're hardly going to have any. For most patients, if we're just treating one area, maybe feeling a little tired, maybe some skin redness, that's usually about it. But if we're treating the total skin, there's more side effects. People can get swelling of the legs, sometimes small little blisters can develop. People don't sweat as much for the first 6 months or so after radiation. The skin can feel dry. So it's just more intense if you do the total skin electronic therapy. So what questions can I answer? Yes.
So my hand go. Being here at Duke.
Yep.
And I'm on 3B at
Okay.
Duke.
Okay.
You know where that is?
Yep.
Do I suggest to her, can we talk to Dr. Kelsey, or would I be a candidate for Dr. Kelsey?
Yes. You mean, so if you're in the Duke Level 3 clinic, you can talk to
Dr. Olson.
Dr. Olson, you say, Dr. Olson, would it be appropriate to have a consultation with Dr. Kelsey? Let's see what she says.
Thank you. I'll see her Tuesday.
Perfect. Any other questions? Yeah, Edith?
How much hair loss do people get, like the total scan?
How much what?
Hair loss.
Oh, hair loss. So basically, everybody's going to have hair loss acutely. If you give a 2-week course of radiation, their hair should come back, because the dose is well below the threshold for permanent alopecia. If we do the full dose of radiation, you're right on the edge. So the full course of radiation is like 36 gray, and if you get to around 40, that's sort of the tipping point where it can go either way. So I tell people, if we're going to do the full course of radiation, the hair should come back, but I make no promises. It can come back different color, different texture. It may not come back. In most people, it comes back.
So, and is there a limit to the dosage, right,
Yeah.
over time?
There is. So, fortunately, the skin can actually tolerate a lot of radiation before anything serious happens. The biggest concern that we have with the skin is that there'll be changes that if trauma were to develop, like they cut their arm, for example, that it doesn't heal. That's what we worry about the most, okay? Now, the total dose of radiation to the skin before we start to worry about that problem is around 110 gray. given over at least a few year period. Okay, now if you get 110 gray all in like 10 consecutive weeks, you're gonna have problems. But if it's spread out over many years, you can give up to 110 gray. So if you put that in perspective with mycoses and other skin lymphomas, we're often giving 10 gray here, 8 gray here. We can often retreat areas many, many times. I think I've only had one patient where I got to that point where I had to tell him, look, I can't give any more radiation to this area. It's just gotten too much over the years. Good question.
I'll ask you, this is about, had some friends recently, they had developed a tumor in the mouth, in the gum.
Uh-huh.
I'm not sure how it got there, they never smoked, anything like that, but that develops into some fatal cancers in the mouth,
In the,
in the gum. It started out just like a little cold sore on the gum line. Is that coming from radiation or from a dentist or from what?
So in that, I don't know. The vast majority of oral cavity cancers are caused from smoking, including smokeless tobacco. But a lot of patients can develop cancers and they've never had any of these adverse exposures. And in most people, we don't know. We have learned over the years that in some people with head and neck cancer who have never smoked, it's from the virus, the human papillomavirus. Now that's usually tonsil, base of tongue, not usually gum. But sometimes we don't know. There's been some patients who it's been attributed to heavy mouthwash that included alcohol. And they usually use a lot of mouthwash. And maybe that was it, we don't know. But it's possible.
Does radiation work the same on any stage of cancer, stage 1 to stage 4? Does it matter?
I think the response to radiation depends on a few things. It depends on what disease are you treating. So there's some, if we look at cancer more broadly, some cancers just don't respond very quickly to radiation, like sarcomas, mesotheliomas. Often we use radiation, we can stabilize the tumor, we can prevent it from growing, but it just doesn't shrink. The vast majority of skin lymphomas, they just melt with the radiation. And it almost is regardless of how big they are. Now, sometimes patients who have bigger tumors, they're at higher risk of it coming back at some point down the road. So yes, it depends. There's a lot of issues on how well tumors respond to radiation, but in the skin lymphoma world, radiation almost always works well for individual lesions. And
So, total skin, I usually think about it for our patients who have kind of the patches or the plaques or the tumors. What about patients who have erythroderma where it's not, where it's just that diffuse redness?
yeah, so if you look in the literature, many studies show that radiation can be effective in that cohort, not as effective compared with the patch plaque tumor stage disease. My personal experience is very limited. At Duke, we've used total skin very rarely in erythroderma patients, and I'll tell you that I have been universally dissatisfied with how well radiation works in erythroderma. So that's one circumstance where there's something going on where the radiation is just not as effective. It's a very good point. All righty.
Questions? Great, thank you so much. How is